Hello, I'm Sheryl McCarthy of the City University of New York. Welcome to One to One. Each week, we address issues of timely and timeless concern with newsmakers and the journalists who report on them, with artists, scientists, educators, social scientists, government leaders, politicians. All are one to one. As we usher in the administration of President Barack Obama, we continue the conversation about what direction the country should take. A most serious concern is how we will tackle health care. Do we aim for universal health insurance or not? And how do we pay for it? Above all, how do we attain optimal health care for all Americans, whether they're born here or came here legally or not? To help us assess these challenges is Dr. Sheryl Glied. She is professor and chair of the Department of Health Care and Management at Columbia University's Mailman School of Public Health. A study published just last week by the Commonwealth Fund found that more than half of Americans with chronic health conditions, such as diabetes, heart disease, high blood pressure, cancer, depression, skip filling a prescription, skip getting a recommended test or treatment, and skip doctor's appointments because of the high cost. And 43% of these are people who have health insurance. Doesn't this belie the notion that the United States has the best health care system in the world? What's going on here?
Well, I think there are two pieces to this problem that are both important to think about. The first question is whether anyone really believes anymore that the U.S. has the best healthcare system in the world. We used to think that that was true, but evidence that's accumulated over the past 5 or 10 years really should raise questions about our belief in that. I think that when we look at our healthcare system, what we see is kind of isolated islands of excellence, these fantastic tertiary care institutions that people fly from all over the world to get care at. But those islands are in a sea of mediocre, uncoordinated care, and people are not getting the routine care they need. The second piece of the problem is that the way we've structured our healthcare system, a lot of burden is on patients to decide whether to use care, whether to go to the doctor, and so on, and to trade off the cost of doing that against what they see as the benefit. And when you look at the statistics the Commonwealth Fund found about how many people are missing doses of meds or not going to the doctor, that's really the second part of this story. We've actually set up our system to make people think twice about whether they should go to the doctor or use medication, and that might not be the best strategy in all cases.
Mm-hmm. Now, our healthcare system is based primarily on the employer model. You know, your employer provides you with a healthcare plan, usually pays part of the premium and perhaps all of the premium, and in some cases you pay a portion of it. But with the current economic downturn and millions of people who have lost their jobs, what happens to them and healthcare now?
Economic downturns are always a dangerous time in terms of health insurance coverage. We know that people lose coverage when the economy softens, and we also know that because of the employer-based system, and also because even people who buy coverage on their own can no longer afford to pay the premiums. So it's both of those things working together. The other thing that happens at the same time is that state governments, with their effort to balance budgets, become increasingly stingy in extending public coverage. So people are really caught in a bind.
Right. You look at people like, I guess it was 50,000 who got laid off from Citicorp the other day. And, I mean, is there any kind of safety net for people who lose their jobs?
First of all, it's important for individuals to know that they can use the COBRA legislation, which is coverage that they buy themselves through their employers.
And that was brought about through federal legislation?
That's federal legislation.
Okay.
It allows people to continue their employer-sponsored coverage for up to 18 months after they leave a job. It's very expensive because they have to pay the full premium, both the employer's share and the employee's share for the 18 months, but it's often the best deal that's out there and available to them.
And is anybody who held a job and who gets laid off eligible for COBRA?
Anyone who had health insurance through their job and worked for, I think there may be a firm size limit on it. It may be that if you were in a very small firm, COBRA doesn't apply.
You know, I have a friend who does freelance editing, and so she doesn't make a whole lot of money. And she tells me she is now paying, a few years ago she was talking about her health care premiums was $200 a month. Now it's, I think, $280 a month, which is a large chunk of her income. Should she have to pay so much?
Well, she's only, I don't know where your friend lives, but if she lives in New York, the only reason she's able to pay as little as $280 is because there's a big government subsidized program for people like that.
Okay.
In fact, if she weren't in a program like that, she'd probably be paying $500 or $600 a month.
Okay.
Depending on her health status and other conditions. That's an awful lot of money. And the question is, as a country, how are we going to protect people, especially lower income people, from those enormous costs? We pay them out for medical care, but the distribution of them is something that we really need to address.
You know, and even those who are employed, have health insurance that's provided through their employers, are seeing those costs, their premiums go up.
Absolutely. All of those costs really depend on the underlying cost of health care, and the underlying cost of health care has been rising faster than incomes for almost as long as we've ever measured it.
Why? Why is the cost of health care in this country so high, you know, for people who need it? I mean, in my view, health care, which is so basic, ought to be cheap. And yet you hear stories of people who are able to get American-produced drugs who are exported to other countries, and they're able to get them in those countries cheaper than we're able to get them here. Why are the costs so high?
So there's, again, a couple of elements that contribute to that. One is that we have a very lightly regulated healthcare system compared to other countries. So in other countries, the price of drugs, the price that's paid to doctors and hospitals, all the prices that go into the healthcare system are limited by the government in one way or another. And those limitations keep costs down in many of those countries, as well as other ways that they manage their healthcare systems to keep costs down. The other piece of that is that in those countries, health insurance is universal. It's universal everywhere else in all the other developed countries of the world except the United States, all the other high-income developed countries, which means that even if the total costs are high, individual patients are not paying terribly high costs.
Right. So, is the employer the best and most stable source of health care?
In our current health insurance system, the employer is the most stable and best source of health care. We would really need to revamp our system to come up with an alternative that would take the employer out of that position. So it's not that going into the individual market at this moment would be better, but if we could come up with an alternative to the employer all around, that might be a better way to go.
Right. During his campaign, now President-elect Obama proposed a plan that will require companies to provide health care for their employees, or companies of a certain size to provide health care for their employees, or contribute to a public fund that would provide health care for them, for the uninsured, in a plan, I gather, that would be similar to Medicare. And I believe he also offered was talking about tax incentives to small businesses to help them pay their insurance premiums. And he claimed that this would cover most of the 42 to 45 million Americans who are currently underinsured. But it all sounds so patchwork.
I think that we've tried to go with comprehensive coverage in the past, and the Obama campaign, I think wisely from a political perspective, decided that wasn't the right way to go right now. Most Americans who have health insurance coverage are quite happy with it. They are very nervous about changing that coverage. So I think the campaign really felt that they wanted to build incrementally from the base of coverage that already existed for a number of reasons, both political and fiscal, and extend coverage to the uninsured. So that leads to a patchwork kind of approach.
Mm-hmm. Do you have any particular, how do you feel about his plan as he's laid it out?
Well, I don't think he really has a plan. I think it's important. I think he has sort of a goal, an idea, and he really wants Congress to take the initiative in developing whatever plan there will be. But I think it's something we really need to keep in mind, that if you look at those other countries that all have universal coverage all over the OECD, they didn't build it in one fell swoop. They all did it incrementally and slowly. They went from one level to the next level. We feel this enormous pressure to get it all done right the first time. I would be really happy if this administration would just push us forward towards universal coverage, even if the system that we wind up with at the end of 2 years or 4 years or 8 years is not the one that we think is absolutely the best in the world.
So, you know, some form of patching so that everybody is covered.
Absolutely. I mean, I think the key is to get everybody covered, and then we can fix it later. I mean, we shouldn't feel like once we've done it, the whole game is over.
Yeah.
That's not the way that healthcare works.
You mentioned Congress. And I have been told that they are the only Americans who are truly covered, who have a truly great health care insurance program. Could you describe what their health insurance plan, and why do you think they're so hesitant to pass that on to everybody else?
Well, they have a health insurance plan that's not so different from most large employers. My guess is that here at CUNY you have something quite similar to what the federal employees have, which is to say that Federal employees have a choice of a number of private health insurance plans with defined benefits, certain benefit designs, different ones. So there's a high deductible plan that's offered, and there are some HMO plans and a couple of other plans. Those who live in Washington, D.C. have a pretty extensive choice of plans. Federal employees who live in other parts of the country have a more limited choice of plans, but they can choose among those plans, just as if you're employed by a large employer, you probably can too. The great thing about it, of course, is that it's Congress, so they have pretty good job security, at least for a couple of years.
Right. You're from Canada.
Yes.
And you know, so many people when they become critical of our system talk about the Canadian system. And I must say that, you know, some years ago I took advantage of the Canadian system and took the train up there to get something I couldn't get here, and they didn't charge me a dime. I loved it. How do you feel about the Canadian model as opposed to what we have here? And why do you think, you know, so the Canadian model, the English model, the European models are so, Americans are so leery of them?
Well, I think part of it is that we have a misconception that what there is out there is one model of healthcare that's, you know, this big socialistic medicine model that politicians like to talk about. The reality is that every one of those countries in the OECD that has universal coverage designs their plan in a different way. So the Canadians have one design, the Dutch and the Swiss have a completely different design, radically different from the Canadian model, and the British are different as well. The only thing that every other country has in common is that everyone's covered. But everything else about their plans could not be more different. The Dutch and the Swiss, for example, they use private health insurance companies. They have competition among the health insurance companies. It looks a lot more in some ways like that federal employees plan.
So it's not a single payer?
It's not a single payer plan. The Canadians have their single payer plan, but the doctors are independent and charge like in our Medicare system. The British employ all the doctors. And the doctors are employees of the government. So that's a completely different plan altogether as well.
Their salaries
they're actually salaried. The Canadian doctors are not salaried. So we have this sort of idea that, you know, there's either it's us or there's this other healthcare system out there. That's just not the way it is. It's us or there's universal coverage, and there are loads of ways to do it.
Yeah, the difference is that those plans are universal.
That's the only thing that really ties them all together is that they're universal, and also that the government believes that it has a role to play.
Right. I used to have often thought that Americans, we have made a choice, a policy decision, that our doctors should be very highly paid, you know, as compared to the choices that may have been made in other countries where the doctors are well paid, but, you know, we've decided our doctors should be able to make a lot of money. I mean, do you think that's true?
Well, what we have decided, I think, I don't know that we've made a decision about how much to pay our doctors, but we've encouraged our doctors to be entrepreneurial. And to behave as if they were investment bankers or lawyers or businessmen in other fields, to open their own clinics at which they can do diagnostic tests and surgeries, to open their own hospitals, to do all kinds of things that in other countries would be viewed a little askance, although not in all other countries. I mean, again, there's a lot of variation there. We also have, in the United States generally, a very skewed distribution of income. People at the high end of the income ladder in the U.S. make much more money than people at the high end of the income ladder in most other countries, and doctors fall into that category. So it's not as though we made a sort of policy decision that doctors should make a lot of money. It's just the way our system has played out. Should also note that the primary care doctors in the United States do not make a lot of money by international standards. You would do just as well if you were a primary care doctor in most of these other countries, and much better in some.
Really? We're going to take a short break. We'll be back with more with Dr. Sheryl Glied of Columbia University's Mailman School of Public Health.
If someone you love has a problem with drugs and alcohol,
he's not expecting this.
Yeah, but it's the right thing.
there is something you can do.
You think he'll be okay with this?
Shh. Here he comes.
You can celebrate his recovery every chance you get. For drug and alcohol treatment referral for you or someone you know, call 1-800-662-HELP.
Welcome back to One to One. I'm Sheryl McCarthy of the City University of New York, and I'm talking to Dr. Sheryl Glied of Columbia University's Mailman School of Public Health. When I talk to just regular people about their health care and their frustrations with it, whatever, they will all say, look, we just need a single payer system. When you talk to public officials, when you talk to university professors, when I talk to people on this show, they will say, well, okay, but you're not going to get it, and so no point in going there. What are your thoughts about that?
What people want is health insurance that they can rely on, that doesn't make them crazy, that doesn't force them to make decisions about how much they have to pay when they want to take their kid to the doctor. I think most people don't have a really great sense, and why should they, of what the potential health insurance systems that are out there are. They want a result for themselves. And I think it's our job, or the policymakers' job, to come up with a way that we can do that and give them what they want. I don't think that if you ask people in those European countries that are not single-payer systems whether they wanted to, in fact, they do this. They ask them, would you rather switch to a single-payer system? They're happy with what they've got. I don't think that most Americans care how the government relates to the doctors or how the insurance companies relate to the doctors. What they care about is how they relate to their doctors, what they pay, and what the total costs are. So that's where we should focus our attention.
So, is universal health care at a moderate cost or free, well, we're not even going to go there, possible? And if so, what do you think it would look like?
My goodness. Yes, it's clearly possible. Look, it's clearly possible because when we, a measure of possibility is, has anyone ever done this before? And look across the OECD, they have, right? They pay, on average, their countries spend half as much as we do on healthcare per person per year. The most expensive country, Switzerland, which has competing private insurance and every lovely technology you like and no waiting lists and all that good stuff, they still spend only 2/3 of what we do per capita per person per year.
So what's kept us from getting there?
There are so many political barriers. There are a lot of concerns. There are lobby groups. Healthcare is the second largest lobby group in the United States. So there's a lot of interests who are opposing moving in this direction.
Is it the doctors who are opposed to it? Is it the pharmaceutical companies? Is it hospitals?
It's everyone.
Who are they?
Doctors, hospitals, pharmaceutical companies. They're not necessarily, let me be clear here, no one is opposed to the idea of universal coverage. Nobody, not even the insurance companies are opposed to the idea of universal coverage. It's just that they're opposed to that piece of it that might have an effect on them.
Okay.
Right? So the doctors are fine with universal coverage, but don't make them accept regulated payment rates. Right? The hospitals are fine with universal coverage, but don't let anybody tell them how many beds they're allowed to have or what technologies.
Right.
The insurance companies are fine with universal coverage as long as they get to choose how much premium to charge. So the problem is always...
And the politicians are fine with it, but, they don't want to alienate their contributors.
And there's also the problem that we already spend more public money per person on healthcare in the United States, per person, than any country in the world except Norway. I mean, we're already extremely expensive. We're spending so much money. And so I think a lot of the politicians are also just worried about how we're going to pay for this and whether the entire government is going to turn into a healthcare financing agency.
But you spend less if you regulate it more, correct?
Absolutely. But they're very nervous about the whole, you will eventually spend less if you regulate it more. But the steps to get there will cost more money in the shorter run. And they're worried about ever getting to the longer run.
Yeah. Medicare is the medical plan that people tend to praise and feel that it works well. I mean, I'm sure there's some problems with it, but I gather a lot of people are mostly happy with it. How does it work, and why can't we have Medicare for everybody?
So Medicare is a plan that a lot of people are very happy with, and that's great. But it does have certain problems from both a public policy perspective and even from an individual perspective. From a public policy perspective, the problem is it's very expensive, and we're worried already about running out of money in the Medicare program to pay for you and I when we need those services. So the cost of Medicare has been growing at least as quickly, sometimes more quickly, sometimes a little less quickly than private insurance. So there hasn't been effective cost containment in Medicare. And that makes politicians very nervous about expanding that program. The second thing that is a little distressing about Medicare is that the plan design was built in 1964. Most people who have Medicare, a large fraction of them, have what's called a supplemental plan on top of it. So they have
to cover
Medicare,
things that Medicare doesn't.
Because Medicare itself is actually a much worse benefit plan than most of us get from our employers.
Really?
It only really works for people if they have that supplemental coverage on top of it. So the question is, you wouldn't want to do that two-level, the layer cake approach, if we were to expand it to everyone, we would really have to go into Medicare and make it a 21st century health plan.
Why are people always praising it?
Because they've got coverage. And once you buy that supplement, if you've got Medicare and you have the supplemental coverage, you have access to virtually every doctor and you don't pay anything out of pocket. And if your employer pays for that supplemental coverage, as many retirees still have that arrangement, then you're really golden. But for those people, if we were to expand just Medicare itself, there'd be a lot of people whose insurance would get a lot worse.
I read a Q&A that someone did with you in which you proposed, and correct me if I don't have it right, taxing healthcare spending and using that money to fund uncompensated care. Could you explain?
Sure. One idea that's been out there for a long time is to think about the structure of our healthcare system. Our financing system has a lot of pieces to it. One of them is that we now provide tax subsidies to people who get employer-sponsored health insurance. You're not even aware of it, but the government picks up part of your health insurance cost through an implicit tax subsidy that you never see. One of the ideas that has been floating, and I should just put my idea there in context, is that we would have universal coverage and everybody would have health insurance. If everyone had health insurance with regulated benefits, then I proposed if people choose to buy more coverage than the regulated benefit, we should tax that extra coverage.
Tax the person who gets
We could put a tax on the insurance company, all right, because that coverage is actually sort of increasing the overall cost of health care for everyone. And then we could use that money to help fund the pool of care. Another place that we do the same thing, and actually we've been doing it in New York for decades, is that we tax all privately insured people who go to the hospital. You don't know it, but it's in your premium.
Really?
And we use that money to fund uncompensated care in the hospitals. So it's another way of kind of redistributing from the haves to the have-nots within the healthcare system.
Okay. What's the first thing you'd like to see the Obama administration and Congress do about health care, and what other steps?
Sure.
I'm asking you for your health
My
plan.
health plan, my chance. Well, I think that the Obama administration has a lot of issues on their plate, and they're going to have a lot of things to deal with. But fortunately, for those of us who really care about health care, two of the issues that Congress has to deal with pretty quickly are health care issues. One of them is the expansion of the child health insurance program, which President Bush has vetoed. And so Congress is going to want to take that up again when they return in the spring.
And what does that plan do, just sort of generally?
So that's a plan that provides state-subsidized health insurance to low-income but not very low-income children. And the expansion that has been proposed is to expand that program to children between 200 and 400% of the poverty line. So that would actually be going up pretty high in the income distribution. Families that are earning, say, $40,000 a year would be eligible for subsidized coverage. It would be a plan that states could take up at state option, and the federal government would provide subsidies to the states when they did that. I would really like to see the Obama administration expand that piece of legislation to really encourage states to go to universal coverage for kids. It's something states could do. They could do. Massachusetts did universal coverage for everyone. Children are actually a lot easier to do than everyone because you can enforce it through schools and other places that we already enforce various health regulations. Kids are inexpensive. And we have these programs already going, Medicaid and S-CHIP, through which we've actually gained a lot of expertise in expanding coverage to kids. So I'd like the Obama administration to open up that legislation, and rather than just pass what's there now, really make it a stepping stone to universal coverage, pushing particularly for universal coverage for kids in those states that chose to go forward with it. The second piece of legislation is legislation to change the way Medicare pays doctors. And that's also going to be something that will have to come up, and I'd like them to take a more comprehensive look at that and think of better ways for Medicare to pay doctors that would provide incentives for primary care and team care and coordinated care for doctors within the Medicare program.
In the 1 minute we have left, how optimistic are you really that we're going to be tackling this problem in an aggressive way soon?
I'm optimistic. I think that President Obama will want to do something for people. He'll want to put a new program into place that will really help people. And healthcare is the missing link, the missing puzzle piece. So I would really like to see them move on this.
Along with a job nowadays.
There's that.
He's got a lot of things to deal with. Thank you very much. I'm sorry, but we're out of time. My thanks to Dr. Sheryl Glied, Columbia University's Mailman School of Public Health, for joining me today. For the City University of New York and One to One, I'm Sheryl McCarthy.